Respiratory distress. Number 8026. Caveats. A. Pulmonary edema in the setting of CHF will usually have corroborating signs such as 1. History of CHF and medications such as diuretics and or angiotensin converting enzymes, ACE inhibitors. 2. Peripheral edema. 3. Jugular vein distension or JVD. 4. Frothy pulmonary secretions. Moving on to policy. BLS. 1. Assess CAB. 2. Position of comfort. Reduce anxiety. 3. Supplemental O2 as necessary to maintain SpO2 greater than or equal to 94%. Use the lowest concentration and flow rate of O2 as possible. Number 4. Suction as needed. Number 5. CPAP for severe dyspnea. Number 6. Airway adjuncts as needed. ALS. Number 1. Cardiac monitoring and ETCO2 measurement as available. Number 2. Vascular access, but do not delay airway management. Number 3. Consider intubation for significant hypoxia, dyspnea, or impending airway loss. Note: ipratropium bromide or adjuvant may be used as a substitute for albuterol when albuterol is not available. Acute respiratory distress. Assess CAB, limit physical exertion, reduce anxiety. Consider oxygen therapy per respiratory distress. Airway management, PD number 8020. Cardiac monitor and SpO2 and ETCO2 continuous waveform with advanced airways. Consider vascular access, but do not delay airway management or treatment. Early contact with receiving hospital. Now we'll go down the flow charts. Asthma and COPD is one, and CHF pulmonary edema is the other. We'll start with asthma, COPD. Under that, we have mild distress or moderate to severe distress. Let's go down mild distress. Mild wheezing, short of breath, cough. Albuterol and Atrovent. Mix 2.5 milligrams albuterol and 0.5 milligrams Atrovent via handheld nebulizer, mask, or inline nebulizer. May repeat albuterol 2.5 to 5 milligrams if persistent dyspnea. Okay. Ipratropium bromide or Atrovent may be used as substitute in existing policies when the policy calls for albuterol when albuterol is not available. Dose 500 micrograms or 0.5 milligrams via handheld nebulizer, mask, or BBM. Single dose only. Do not repeat. Moving on to moderate to severe distress. Coming with cyanosis, accessory muscle use, inability to speak more than 3-word sentences, severe wheezing / shortness of breath. Same thing. Albuterol / Atrovent, mix 2.5 milligrams albuterol and 0.5 milligrams Atrovent via handheld nebulizer, mask, or inline nebulizer. This is the difference. Continuous albuterol for persistent dyspnea for the moderate to severe distress. Non-invasive ventilations, NIV, and then moving on, epinephrine, 1 to 1,000, 0.3 milligrams IM for patients with severe asthma / bronchospasm only. Can be given at the same time as albuterol. Note: epinephrine should not be used or should be used cautiously in patients greater than 35 years old or with a history of coronary artery disease, CAD, or hypertension. Okay, moving on to CHF pulmonary edema. We have the mild distress and the moderate to severe distress. We'll start with mild. Mild wheezing, short of breath, cough. If wheezing present, same thing, albuterol and Atrovent. Mix 2.5 milligrams albuterol and 0.5 milligrams Atrovent via handheld nebulizer, mask, or inline nebulizer. May repeat albuterol 2.5 to 5 milligrams if persistent dyspnea. Okay, this can also be done with nitroglycerin, 0.4 milligrams sublingual every 5 minutes. Hold nitroglycerin if SBP less than or equal to 90. Okay. Do not administer nitroglycerin if patient is taking PDE-5 inhibitors within the last 48 hours for erectile dysfunction or pulmonary hypertension. Examples are Viagra, Cialis, or Levitra. Okay, going over to moderate to severe distress. Cyanosis, accessory muscle use, inability to speak more than 3-word sentences, diaphoresis, pedal edema with the CHF and pulmonary edema. If wheezing present, albuterol atropine, mix 2.5 milligrams albuterol and 0.5 milligrams atropine via handheld nebulizer, mask, or inline neb. May repeat albuterol 2.5 to 5 milligrams if persistent dyspnea. So in all of them, asthma mild, CHF mild, and moderate to severe, all of those are the same. The only one that's different is the asthma moderate to severe. That one's the only one that gets the continuous albuterol. Okay, moving on. So after the albuterol and atropine, you can titrate nitroglycerin depending on the BP. So SBP 90 to 150, 0.4 milligrams sublingual. SBP 150 to 200, 0.8 milligrams sublingual. And SBP over 200, 1.2 milligrams sublingual. May repeat titrated doses every 5 minutes based on repeat BP. Hold nitroglycerin if BP is less than or equal to 90. Non-invasive ventilations for severe distress begin concurrently with albuterol and nitroglycerin. Use nitroglycerin paste if CPAP already in place. Okay, and then we can also use push dose epi, epinephrine, 0.01 milligrams per milliliter, 10 micrograms per milliliter. Dose is 0.5 to 2 mLs every 2 to 5 minutes, which is 5 to 20 micrograms. Titrate to SBP greater than or equal to 90. Note, monitor SBP while administrating titrating push dose epi. And that is the end of respiratory distress 8026.